Hi there. My case is titled The Predictive Value of Combining Diagnostic Technologies. My name's Paul Chous. I'm an optometrist in Tacoma, Washington. I have a practice that emphasizes diabetes care. I'm an adjunct professor at the Western University College of Optometry. I've been using the RETeval the last couple of years. I had some prior experience with the technology about 5 years prior, and when the RETeval became available with a global indice of retinal function, I became reinterested in the technology. I primarily use the technology for the diabetic retinopathy assessment. I've been starting to use it in patients with glaucoma or glaucoma suspicion as well. I primarily use the device, though, the FERG combined with pupillometry in patients that I've established they have some degree of diabetic retinopathy. So here's my case report of combining structure and function. It's a 39-year-old white male with type 1 diabetes for 18 years. He's on an insulin pump, and so a continuous stream of insulin, and then he takes an extra bolus of insulin with meals. His recent hemoglobin A1C is 6.4%, but that's not important, really. What the patient's current A1C is, what you should be asking patients is, what's your A1C been since you were diagnosed with diabetes? And when I looked at the chart, he had hemoglobin A1Cs going up to above 12%, had a history of poor glycemic control for a number of years before he finally tightened things up. He wears a continuous glucose monitoring system, and he has a 90-day time in range of 64%. So his blood sugar's in a relatively normal range between 70 and 180 milligrams per deciliter, 64% of the time. The goal for most patients is to have that number be at 70%. The higher the time in range, the better. When I looked at his time below range, and that assesses hypoglycemia, he actually had about 15% of the time his blood sugar was below the normal range. He's on insulin aspart Novolog, and he takes between 60 and 80 units a day. That's a fairly high amount of insulin, suggests that the patient probably has some degree of insulin resistance laid on top of his type 1 diabetes. We know about 40% of patients with type 1 diabetes suffer from insulin resistance. So they're developing, a form of type 2 diabetes laid on top of their type 1 disease, sometimes referred to euphemistically as type 1.5 diabetes. He's also taking levothyroxine because he has autoimmune Hashimoto's thyroiditis. So at original examination, he had mild non-proliferative diabetic retinopathy, a few microaneurysms, not that many, you'll see in a moment. His family history includes a primary open-angle glaucoma, his maternal grandmother. He's not on any ocular medications, hasn't had any procedures or surgeries. And here are his original fundus images, and you got to trust me, the images don't show it that well, but there's a couple of microaneurysms here, scattered microaneurysms, but specifically doesn't have any vein beating or 𝐼RMA that are indicative of more severe retinopathy, doesn't have any neovascularization elsewhere or on the disc, doesn't have any diabetic macular edema. He sees 20/20, his intraocular pressures are normal. Here's just his OCT, which looks beautiful. I did an OCT-A, and what you can see, I showed the left eye just because it's the eye really that's the most interesting in this case, but there's significant areas of non-perfusion here. No evidence of proliferative retinopathy or 𝐼RMA. So I did the RETeval test with this patient, and he had an abnormal DR score of 25.5. So in general, we know if the score is above 23, the risk of needing a retinal intervention, that is laser or intravitreal injections, goes up dramatically. So this patient, because of his high score, has a high risk of needing a retinal intervention in the next 36 months. So I did this as a baseline measurement. I had already done the OCT-A. I wanted to see how his retina was functioning. And what you can see if you look at the ERG is that the amplitude of the B wave, that's the peak of the sine wave you see there for each eye. Right eye's on the left, left eye's on the right. It's in the lower end of the normal range. And it wasn't really flagged by the RETeval algorithm. What was flagged as being abnormal was the implicit time, the time it took for that initial wave, the initial response from the photoreceptors to be generated. So that's out of the normal range. And he has reduced implicit times more in the right eye than the left eye. And what reduced implicit time suggests is retinal stress. When the B wave, that peak of the sine wave, gets reduced, and it's on the low end of normal, that suggests that there is photoreceptor death. So I recalled this patient sooner than I would have otherwise because he had an abnormal OCT-A and he had an abnormal 𝐅𝐨𝐜𝐮𝐬 test result. So I reappointed him in 4 months. If I had only gone by the fundus imaging, I very well probably would have seen the patient back in a year. And this is what happened when he came back 4 months later. These are the images 4 months later. You can see there's a lot more obvious retinopathy here. And if you look at the left eye in particular, look at that optic nerve. This patient now has developed proliferative diabetic retinopathy. Just to zoom in on the optic nerve, what it looked like then 4 months earlier and what it looks like now, just to highlight this tuft of neovascularization. So this case really demonstrates the value of combining diagnostic modalities. It all starts with a clinical exam, obviously, but by combining more sophisticated technologies, in this case OCT-A, with the RETeval device, I was able to follow the patient up in a more timely fashion and detect his sight-threatening retinopathy earlier than I would have otherwise. Patient was referred to Retina, who actually decided to monitor him for a while. So we'll see. My suspicion is ultimately he's going to end up getting panretinal photocoagulation or anti-VEGF therapy, or perhaps both. So that's my case. Thanks very much.